can be interesting, I suppose. You need a bigger water bottle?
Oh.
Why is that water bottle so big? It's like a gallon water bottle.
64, Stanley.
Excellent.
Her name is. Oh my God! Did you see that? Their new lunch boxes. I don't want to buy it tomorrow. Yeah, literally. I do like to purchase things.
You're such a handful. All right. All right. EKGs and ECGs. Y'all know the difference between an EKG and an ECG is?
Mm-hmm.
What?
What?
Do y'all know the differences between these two things?
Oh no.
The same. Yeah.
Same.
One of them is a German spelling. You spell where this thing was invented. You spell it with a K. Cardia with a K. But Americans ECG.
I thought you said, have you ever heard of it?
Yeah. So we're going to be talking about a lot of this stuff today. So we're going to talk about some background on electrical conductance. So this one does have a handout online. So if y'all need a refresher about all the electricity of the heart, give that a read. We'll go over it briefly today, but that's like a nice little on paper, everything you kind of need to know. Oh, you printed it out? Yeah. So let me see it real quick. Yes, it goes over like all of the revenue starts and what it is. And that's going to be important for some of the stuff today. So, so cardiac action potentials, there's two major types. There's nodal pacemaker cells and there's cardiomyocytes. I'm not going to be going over all of the heart physiology because hopefully y'all have seen this. Was it last semester y'all took physiology? Yeah, so hopefully y'all seen this before. And so it's a whole bunch of action potentials that kind of flow through the heart. So as you can see here, it all starts in this sinoatrial node or the SA node, and then the electricity will move down to the AV node, the atrioventricle node, right between the atrium and the ventricle, and then it'll move through these what are these? The Purkinje fibers? Yeah, I'm sure it's on here.
Yeah, the bundle is.
Yeah, there you go. It'll move through these fibers down to where you can get these to stimulate the ventricles for contraction. And so what you can see here, the major thing I want to get at is that it's kind of moving to the upper left, looking at the heart, the upper left to the bottom right? And there's like almost a linear flow until it branches out at the end of electricity throughout the heart. And so what you can do is you can have all these different ways to pick up what the movement of voltage is through the heart. And so that's where all these that's where the ECGs come from. And there's a whole bunch of different, they're called leads. That's where it's just measuring the potential. Yeah, I don't want y'all to focus too much on this, and y'all won't need to know like where to attach anything or anything like that for this class. But there's a lot of like history here. The guy who put this together was Einthoven. And he put it on the hands and the leg, and he made this triangle, and they call it Einthoven triangle. It's the first one, so for historical relevance. Now, what's important here, and the reason why that works so well, is that you need something that can pick up the electrical conductance parallel to what the directionality of which way the electricity is flowing. So the fact that your heart's center of your chest pointed downward slightly to the left, so you need something that follows that same electrical conductance. So parallel to the strength of detection results from how parallel the waves is to the ECG lead axes. But again, y'all don't need to know these too much. There's a whole bunch of vectors that y'all can honestly just delete these slides if you want. Well, hold on. The combination of electrical signals, extreme power. You'll see that in lead. Yeah. So y'all can don't focus on these leads, where they're placed, all of that. There's extremely complicated diagrams you can see here. There's like in a classical like EKG, there's up to 12 different little spots you can look at in the ECG. We're going to be focusing, and everything we're going to be learning today is about this lead 2, which gives honestly the best view of what's going on with the heart, both the P waves and the QRS complex, being an ideal for detection of arrhythmias. So arrhythmia is just wait, what? So you can. So I mean, now they just place these things in
Random spots.
not random, but classical. Yeah. So I don't know. You can technically do these in different ways. I don't know what y'all seen. But I don't know. It's more of a clinical thing. We're going to be going over just like what the graphs kind of look like and then what they mean today.
So you delete the
Lead 2.
the vector stuff?
What? Yeah, you can delete these 2 slides. Another 3 vectors, precordial chest leads, V1 through V6. So it's just other ways of measuring electrical conductance. It's important. This stuff is very nuanced, though, and there's a lot to these stuff. One lecture, just like pretty much everything in this course, is not enough. And people, I mean, they become masters on EKGs and kind of reading them and stuff like that. But okay, so we have this EKG. This is what a typical lead 2 looks like. We have the P wave, the QRS complex, and then the T wave. So the P wave represents your atrial depolarization. And when we say depolarization, we mean contraction of that thing, right? Because whenever the electricity hits that area, there's a muscle contraction. That's like a correlation there. So whenever we say atrial depolarization, we get contraction of the atrium first, right? And then we have this QRS complex, which is a massive burst of electricity through the heart. And what that mostly represents is the ventricle depolarization, meaning that's contraction of your ventricle. So this is how you send blood outward from your left and right ventricle. There's also an atrial repolarization, but it is masked by this massive amount of electrical activity at the QRS complex, and so you don't see it on an EKG. But after the ventricle depolarization, we get a ventricle repolarization, which is the T wave right there. And you can see here between the S and the T segments, you can see that ST segment right there, and that was really important for the type of myocardial infarction you have, insofar as if you have a N-STEMI versus a STEMI, right? An ST segment elevation myocardial infarction. So importantly, what we need to recognize is that this SA node in the top left corner, it starts everything. And so because electricity is flowing from the top left into both the left and right atrium, that's what causes that SA node regulates atrial depolarization. And that's the first step, right? And so the fact that the electrical impulse is starting from the SA node is very important, because it's going to send it downward and to the right, the electrical potential downward to the right, and so it depolarizes everything in the proper order. Then you get atrium depolarization, you get a small little a lag until you stimulate the AV node, and then the AV node is going to stimulate the ventricle depolarization, which is the QRS complex. Does that make sense? And then the T node is just everything repolarizing so it can have a second heart, right?
So that SA node regulates depolarization?
Yes. Mm-hmm. And then the AV node is going to regulate ventricle. But the SA node also regulates the AV node as well, right? So there's an order of things. It's SA node, atrium, AV node ventricle for as far as depolarization goes, right? And so whenever these things get out of order, that is when your heartbeat doesn't beat in the proper rhythm, and so that's what the arrhythmias that we're going to study today are. So the normal rhythm is just that, right? Where you have normal rhythm originates from the SA node. There's a P wave before every QRS complex. The P wave is in the same direction as the QRS complex. That's important. So it's both going upward from the baseline of polarization. There are these little dips, right? But I'm talking about the major peaks here. There is a P wave before every QRS complex, atrial depolarization followed by ventricle depolarization. Yes, that's kind of all I was saying there, right? So there's these normal intervals, right, where when you're looking at an EKG, you can expect these kind of distances between the lines, but I'm not going to test y'all like that specifically on all these numbers and y'all's ability. That'll come through experience if y'all see these enough, right? Y'all can delete this asterisk. I don't know why I put that there. Well, so what I want y'all to know is just generally, I mean, this slide isn't, don't memorize the numbers for sure. This slide doesn't really say anything other than the numbers, so it's not a critical slide, but what I do want y'all to recognize is what a normal contraction looks like, right? This P wave, and y'all see what I'm talking about when we get there. What a QRS complex looks like, and then an ST segment, and then that T wave. We're not going to talk about that U wave very much, but then there's a second P wave after that, right?
Don't worry about the U wave.
Yeah, for sure. So what what this PowerPoint and test questions are going to be is a lot of, it's going to be, the first one is determining the heart rate. You're going to have a heart rate question, and you'll see this on the practice test as well. You're going to have a heart rate question, and then I'm going to give y'all a whole bunch of these different arrhythmias, and then y'all just have to generally identify them. And that's kind of that's all. The other 4 questions are going to be, here's this thing, what is it? And different variations of that, pretty much. So the first thing is determining the heart rate based off of looking at an EKG. So the easiest way to do this is to count the number of large boxes. So there are 5 smaller boxes within one large box. And so you can just count, and I'm not going to be like, there's not going to be decimal places. There's only going to be a multiple choice here, so y'all see what I'm saying. But like the math's going to be easy. You don't even need a calculator for this stuff. So all you do is you divide, if you have one box, so you look at the QRS complex from here to here, from QRS complex to QRS complex, and you count 1, 2, 3, 4, 5, 6 boxes in between the 2 different peaks. And you can theoretically pick any points along the whole wave, but QRS complexes seem to be pretty easy. And all you do is you divide 300 by the number of large boxes to determine what the heart rate is for each person. Does that make sense?
For instance, this would be 300 divided by 6. Oh, I'm sorry.
Yeah. No, you got it.
On the PowerPoint.
You nailed it there.
Yeah.
Boom. 300 divided by 6 is 50 beats per minute. And that's typically pretty slow, and so that would be bradycardia. Mm-hmm. So you'll see, that's just how you determine heart rate from these EKGs. It's pretty simple, right? Y'all can do that pretty easily. So arrhythmia, right, is abnormal electrical activity of the heart causing the heart to pump less effectively. There can be weakness, fatigue, low blood pressure. Obviously, you can see heart attacks on these things. Heart rate's affected. Heart rhythm, which is your sinus, is the site of origin you'll see, and then the complex is on the ACG, whether it's a narrow or a broad band. And you'll see this slide will make a lot more sense as we go through more examples about what we're kind of looking for here. So these are the 4 big questions you want to be asking yourself as you look at each EKG, all right? And so you want to ask, is there a P wave? with every QRS complex, because some of them, like, it skips a QRS, or it skips a P wave, or they'll be like overlapping, and so you want to be looking for a P wave with a QRS. Is there a PR interval, and is it consistent? Is the QRS complex normal, right? Because you want it to be very narrow and stuff like that, and you'll see some arrhythmias that aren't normal QRS complexes. And then what is the ventricular rate? What is the R to R interval? Meaning, what is the heart rate, right? If it's fast or slow, that's going to tell you if you have brady or tachycardia. Yeah, exactly. So this is this is what the normal slide will look like, right? Where you have an SA node. This is your normal heart rate, and I want y'all to know that. So 60 to 100 beats per minute is in the normal range. If it is 50, for example, that is Brady, like we saw. And if it's 120 or whatever, it's very fast, right? So, and so I want y'all to know, know that range for sure. Because probably the question will be something along the lines of, here's this EKG, calculate the heart rate, is this bradycardia or tachycardia, and then those would be like your options. But unless you know how to calculate the heart rate, you don't know.
5 boxes, right? So divide by 5.
Let's see. 1, 2, 3, 4, 5. Yeah, 5.
It's 5.
Yeah.
Okay.
So yeah, 300 divided by 5, 60. So this is normal. Yep. Sinus rhythm normal. So QRS complex normal, conduction is normal. So it's starting at the SA node, right? And just everything we talked about to this point is true for this slide, right? It's true for normal. And the rhythm is normal. Everything looks good, right? So what we're going to be talking about is disorders seen in the ECGs there at the bottom, right? And that's going to be the rest of this slide, or the rest of this PowerPoint. So sinus bradycardia is where you have a very low heartbeat, right? So this is between 40 and 60. We saw this already. And so what you're going to be looking for, when you go through that flow chart, are those 4 things that you're going to be looking for to determine what's going on here, is you're going to be looking for the box to box and then calculate it, and you'll see that it is less than 60. But everything else looks pretty normal, right? You got a QRS complex. You're originating from the SA node. Everything looks like it's very drawn out, but other than that, it's a very normal PQRS, and then it's a normal ECG. It's just very, very slow heartbeats, right? So, and this doesn't have to be a bad thing necessarily. Like if you, big time athletes, right? They're such in shape that your body doesn't demand any oxygen while you're sitting in a doctor's office. So you don't need nearly a normal heartbeat. And it's very normal for those people. There's different drugs that do this. Old people's heartbeats don't go as fast. It's not necessarily a bad thing, but this in combination with a couple other symptoms, it might be. So it's like just an important thing to monitor and be able to monitor. Right? Y'all don't have to. Y'all can unbold this title slide, but y'all need to still know that, right? Title slides I don't typically bold and not, so I don't want y'all to be confused by that's bolded, that's not bolded. Oh, we don't need to know this whole slide, but it's like no, y'all need to know this slide. But right, this is just the same thing, just faster, right? So this is tachycardia. So we got a normal PQRS wave. It's just happening very, very quickly. You can see here, there's like 2 boxes in between. So that's like a beats per minute of 150, which is very, very fast, right? Just at resting. Oh. Yeah, I don't know what that is.
So whenever I stand up, my heart rate goes up to like 130.
Oh, dang. And then it slows down over time?
Yeah, and then my blood pressure drops. So.
And you feel it whenever it's happening?
Do you feel pain? I've had some fainting episodes before.
Oh.
Break out in a sweat.
Yeah, that's crazy. Well, there you go. That's what you're...
Oh, God, no. I typically always
Well, that's what your EKG looks like. Not
Yes.
bad. So yeah, everything looks pretty normal. So expectant patients who are, all right, people who are nervous, never been to a doctor's office before, that happens a lot, right? That's just like your sympathetic nervous system going haywire. So that's elevating
Mine
your.
does when I go to the ER. Because I'm like, oh my God, they're gonna tell me I have cancer. I start thinking like,
Um, just don't freak out. Like just assume you don't have anything bad going on
I
until.
actually get nervous when I get shots. I do. I hate needles, but I got like 9 tattoos.
Good.
Did not ask.
Great. Also, people who are in pain have elevated heart rates. So again, not necessarily a bad thing, or if they were running, apparently. Not necessarily a bad thing, but something you want to monitor. Because there are certain symptoms that are associated with just high heart rate. And you can see that in EKG. So the first like really weird one that's not just kind of your average one is your atrial flutter and atrial fibrillation. So what's going on here is you have a whole bunch of random firings along the entire atrium that do not originate from the SA node. And so what that means is that you have a whole bunch of random initiation events of the heart beat. And so sometimes you'll have a random if you have an atrial fibrillation, you have a whole bunch of random intermittently dispersed PQRS complexes, right? That there's no like regular rhythm to your heartbeat. And then this contrasts to atrial flutter as well, where which is not as bad. This isn't as bad as ventricular fibrillation, which we'll talk about later, because you're still getting an original, like you're getting a electrical impulse originating in the atrium, right? So you can still go through a heartbeat to a certain degree, and you still have like ventricular contraction after your atrial firing. So like you still have a QRS complex and you're still getting blood through the heart, right? The problem becomes whenever when ventricle fibrillation happens. That's very bad, and we'll talk about that in a little bit. But it's important to note that, and this is how you tell the difference. I want y'all to make note here that with this atrial flutter, you got this sawtooth pattern before the QRS complex. But importantly, you still have a QRS complex. You still have ventricle contraction. So this whole four little spikes before the QRS complex that you see on the bottom left corner here, that is your atrial flutter. And whenever you have, and you'll see this later, with ventricular fibrillation, it looks almost the same, just you don't have those QRS complexes, and that's how you can tell the difference between the two. So I want y'all to make note of that, the flutter compared to the with those QRS complexes. But
so AFib is like
so you get a whole bunch of firings to the atria, and so it's not as bad as ventricular fibrillation, but it's not being properly expelled from the atria into the ventricle.
So how long does it take for you to die with AFib?
So you don't necessarily die through and through with AFib, and I'm not sure.
Like 50 to 30.
Yeah, that is very fast, right? And it's because you're just like firing off. But yeah, I don't know how long different clinical manifestations happen with this stuff. But that's a good question. You can look into it. And I think that's all. And then your atrial flutter can progress into atrial fibrillation as well. So it's something, but again, atrial flutter is not nearly as bad as atrial fibrillation. So it's something you definitely have to monitor and try to correct for. Okay, junctional rhythm. With junctional rhythm, hold on. With junctional rhythm, what's happening here is that the original impulse is starting at the AV node, meaning that you didn't really have you didn't have the proper order of the electrical impulse, in that it didn't start in that top left corner where the SA node is, and so you don't have atrial contraction, right? And it's even made weirder by the fact that you do have electricity that's going upward from the AV node. So it's starting like in the middle of the heart, and then it's expanding to where your atrium and your ventricles are stimulated by that same impulse, and so the P wave is going backwards. Okay, and so what that's going to look like on an EKG is that you can see that there is no P wave in front of the QRS complex. First of all, right? You see what I'm saying? Like, look at that middle with the highlighted one, the middle wave and the highlighted one. There's no P wave in front of it, and that is because the P wave is stimulated after the QRS complex, but it's also upside down if you look. It's upside down because you're measuring it backwards. Like when the detectors are picking up the electrical stimulus going up and to the left, like that's the direction of that vector. And so when it's supposed to be, the movement of that electricity is supposed to be down and to the right. So it's like it's off. So it's looking upside down on your
Who came up with this again?
that Evenheim dude, Ovenheimen, whatever his name is. So inverted. So yeah, your P wave is inverted, and it's in between your QRS and T waves. So it's not in front of your QRS complex like it's supposed to be, right? It's like shifted over. That's because it's stimulated at a different time. So yeah, impulse starts in the middle and have forward and backward movements. Make sense? Junctional rhythm. We also have premature ventricular contraction, PVC, and that is where the impulse originates from the right ventricle and goes outward from there. Now, these necessarily aren't bad, and honestly, probably most of you, if not, like all of you, have had this happen at one point in your life. Things like this happen when you do things like sneezing or hiccuping and like those kind of innocuous events that happen. It has like effects on your heart sometimes, and it happening one time doesn't really matter. It's when it becomes a regular problem is when that really, yeah, in a certain back-to-back function, yeah, sneezing, etc. Right. So yeah, it's normal to have occasionally, but bad if they regularly occur. And so what you're really looking for here is a weird, it almost looks like it's just like a blip, and it's like trying to be a QRS complex. It's like that steep one. What we're referring to specifically is this like, it's like a box big right here. This is your PVC, right? And so yeah, right here. And because it's not originating from the SA node, right, there is no P wave before it, right? You can see that here. There's no P wave stimulating this. It's originating from the ventricle itself. That makes sense? You see what I'm talking about? So this wave right here is not a P wave, right? This is your ventricular repolarization, right? So there's nothing going on right here. So there's nothing going on there, right? Because you need to finish the first heartbeat first. Right? Boom, normal, repolarization, boom, normal, repolarization, random QRS complex that's very, very wide. There's like a repolarization that happens, and then you go back to normal after that. Yeah, premature wide, not measurable. So yeah, know what these look like. So we also have ventricular tachycardia, This is really bad and can absolutely result in death. You need attention immediately. So you can see the first thing is that you have a very high heart rate, between 100 or above 100. You have a very wide QRS complex. It's not very, like when we look at, like this is very, very thin, right? This is what a normal QRS complex looks like. All this is bad, but like that's a normal QRS complex. Here you can see how wide that QRS complex is. And so it's also happening back to back. You don't have proper polarization, repolarization originating from the SA node. And so, and it's just a very, very bad that your heart is trying to really, really pump very, very quickly. And it's, you're not going to get proper blood flow through the heart from that kind of thing. What's great about these things, though, is that they all look appreciably different from each other, except for maybe this atrial flutter, and what we're going to be talking about next, which is this ventricular flutter. But even that, it has a noticeable difference in that there's no, there is no QRS complex here. So yeah, the next thing is ventricular fibrillation, and that is where you have a whole bunch of random firing events happen from the ventricles. So what that means is that you just have a whole bunch of random contractions of the ventricle trying to send out blood, but there's no blood entering from the atrium, and it's absolutely bad, right? It can look like atrial fibrillation a little bit, but it can kill patients, and they need attention immediately. And so this is why you use a defibrillator, right? There's like, and I don't talk about the electrical things that you shock people with. So you all know what fibrillation means? So it's just that. It's like a whole bunch of electrical stimulation of the heart. So a defibrillation means you are trying to stop all electrical activity of the heart. And so yeah, it's like starting out. It's like let's stop with all that, and then we're going to start over, see if the heart can just start beating normally again. That's the exact theory behind a defib or defibrillation. Yeah, the little shocker thing. Clear, you know. And so so yeah, obviously you don't have any appreciable contraction of the heart. It's originating from the wrong spots. Like this is really, really bad problems. There's not even really an appreciable heart rate because just it's almost like a flat line. We don't have any contraction of any appreciable contraction of the ventricles at all. So I guess what I'm trying to say is even the little distances between the tops and the bottoms of this of these waves, that's not going to contract your ventricles, right? You really need a large QRS complex to have appreciable contraction. Makes sense? And then PCR also helps. It's like a different regulation than electrical. It's like trying to force the blood in properly so that the electricity starts to flow again. It's another thing. Okay, so we also have if someone is wearing a pacemaker, they don't have a normal heartbeat because they don't have the origin of the electrical impulses starting from the SA node, right? You put in a pacemaker, and it's wherever that pacemaker is inserted, that's where the origin starts. And so what's great is you get contraction of the ventricle, right, and you get proper blood flow to a certain degree through the heart. The thing is that it's not going to look like a normal heartbeat, right? And so you're going to have like a weird looking EKG. But the heart rate's going to be normal though, if it, as long as everything's working properly. And but the QRS complex is going to be notably wide. So yeah, just make note that it's a different thing. So you also have this long QT syndrome. It almost looks like you get these twisting peaks. And this is really, really bad for patients when this presents, or when you see this on an EKG. and this is like a genetic problem with abnormal sodium-potassium channels. And then there's also some medications that lead to long QT syndrome as well. Maybe caused by hypocalcemia or hypercalcemia. Results in episodes of palpitation, fainting, sudden cardiac death, can progress to fatal arrhythmias. You get these twisting peaks, and very hemodynamically unstable. So what that means is that you don't have proper blood flow from the heart. It's kind of like your ventricular fibrillation, where you're not getting proper, consistent blood flow to the heart. You can kind of see that on this graph. But all right, heart blocks. So this is where your heart beats slowly or arrhythmically, and there are 3 different heart blocks, and then there's kind of 2 categories of the second one. Have you all heard about these before? Or Mobitz type 1, Mobitz type 2. Some people heard. Okay, well, that's good. There's different ways to identify these. So the first one, there's different ways to identify these. The first one being that, with heart blocks, they get more severe as you go down the list. So a first degree is not as bad as a third degree. And then a Mobitz type 2 is worse than a Mobitz type 1 as well. And with this is that, so if you have a first degree block, these are typically benign and can even be asymptomatic. And all that it is it's where you have that PR is longer than 1 box long. Typically, that's only going to be 1 box long. So if it's 2 or 3, that's what you want to be looking for with these first degree AV blocks. Now, with this can progress to a second degree AV block, and where you have the same is true where the PR, it just gets longer and longer, and then what will happen is so you can see the PR segment. I'm trying to see these arrows. The PR segment is super short, almost normal, probably normal, right? And then it's getting longer here, even longer here, and then what will happen is that it gets so long that it just completely, like you'll have a dropout of the QRS complex through and through, and then you'll start off normal back again, and then you'll repeat. So it's like
Does that happen like repeatedly?
So it's yeah. So this is Mobitz type 1, which is a second AV block, and that's how you identify them. And then with type 2, you get the PRs fixed, but then you just randomly drop a QRS complex. So with this, you can see this is a this is a T segment from the other wave.
Okay.
Or sorry, no, that's probably a P wave. Sorry, that's a P wave. It goes into a QRS. P wave, QRS. QRS, T, P, QRS, T, and this is a P wave right here, but then there's no QRS right here, right? So you just have a random dropout of the QRS complex here, right?
The P's look so
Yeah, what right, yeah, so through and through arrhythmia. The as far as like seeing these things, I would just look for like a small wave, big QRS complex, and then another smaller wave for at least testing purposes or something like that. So where you got to see that. Don't get tripped up by the distances between these things because yeah, these are very inconsistent. But you can see here is that there needs to be 2 waves in between QRS complex, 2, 2, and here's 3, right? And here's 3.
Okay.
So that's what I would look for in this. Atrial and ventricular are acting independent. So yeah, what's going on here is that because, so you with the heart is being stimulated. You're supposed to go from the SA node, contract the atrium, AV node, which contracts the ventricle, right? And there's that order. But the SA node stimulates the AV node, right? The upper left corner stimulates the middle, and you have a flow through the heart. The problem with this is that they're acting independent of each other, and the atria isn't regulating the ventricle contraction, and that's a problem because when you talk about the blood flow that follows the electrical contraction, you want blood in the atrium and then that to be contracted to the ventricle, and then now that there's blood in the ventricle, it's contracted out of the ventricle, right? If these are acting independent of each other, you don't have the proper blood flow in that, just like you didn't have any filling of the ventricle and now your ventricle's contracting, or you didn't have any, or you already got rid of the blood from the atrium and then the atrium's contracting again without having any blood in it and stuff like that, right? So they're acting independently of each other. And then third AV block, you don't have to worry about. You just don't have to worry about. You can just know that it can be caused by a parasite. There's like problems with this. There's problems with testing purposes for this. The P wave and the QRS complex are disjointed, and they are acting independently. The problem with this, from where I'm coming from, is it's hard to test on this because I don't want y'all to get this confused with the Mobitz type 2 or other stuff, because it does look kind of similar. And so I won't ask a question about this on the test, but if y'all want to know just for here, that it's interesting here is that, so this is mostly caused by a parasite, and the parasite infects your heart, and it blocks the electrical conduction from the SA node to the AV node. And so you still have 2 independently functioning things, but you don't have a proper electrical conductance to the heart. So again, these things, so the QRS and the P wave, they're acting independently again. But it's really, really bad because it's being blocked there. Yeah, so you can kind of see it in this. The Purkinje fibers. I guess I never said that. What an AV block is, I should have started it this way. What an AV block is you are blocking the electrical conduction from the AV node, right? That's what we mean by AV block.
From the AV node?
Yep, and you can see it best here, right? But all of these, like, you don't have proper conduction from the AV node. All right, and the last one we've seen, sorry, this isn't the last one, but this one we've seen as well with STEMI versus in-STEMI. So what's going on here is you're looking for that ST segment and whether or not it's elevated or dipping down. Normal, it should be flat just after that depolarization, and it's waiting to be repolarized. But if it's elevated like that, it's a STEMI. So just be able to recognize that, right? But we talked about those last lecture pretty extensively.
This exam I'm asking you that. I know you got it.
So it's not this week, it's not next week, but it's the week after.
Yeah.
On 8 lectures. Yeah. So so this is an interesting one as well. It's more common than you'd think. But so what's going on with this one is that you have stimulation of the SA node, stimulation of the AV node like normal, But what happens is that there's a reentry current that excites back the AV node. And what I mean by that is that whenever you have the SA node, it's stimulated, it goes here, and then this is typical that it goes here, and then it contracts the ventricle, and then that's all it is. What's up?
I just wanted to see if you have these students to get their parking pass. Sheena, Destiny, and Laura.
Yeah. Wait, Laura? I don't think we have a Laura.
Okay. Thank you. I'm sorry to interrupt.
No, you're good.
Are we visiting students?
You're not really visiting, but you know.
Okay. They won't be going up on my.
I think it's just like because medical students are like your normal student that y'all have like y'all have a shorter like y'all's only 2 years long, right? So it might be not like a 4-year program like with them. So that I don't know. This place
anyway.
This place is weird. Anyway, so what's going on here is that you have stimulation of the SA node. It goes down to the AV node. The AV node is supposed to just disperse out and contract the ventricle. What's going on here is that some of that current is going to go down, stimulate the ventricle, yes, but some of that current is going to feed back and re-stimulate this AV node, or not, re-stimulate the pathway to where you have a really, really wide contraction at the QRS complex. And so you can kind of see what's going on here, that this is normal, and what you're looking for here is this wide QRS complex on the EKG. But it's just it's a stimulation of this bundle of KINs, causing excitation of the AV node.
So whenever you have the SA node gets stimulated, it contracts the ventricles and re-stimulates the pathway.
So not the SA node, the AV.
AV.
Yeah, SA node. The SA node, the AV node is pretty normal. Yeah.
And then it re-stimulates the pathway, and then there a wide QRS contraction occurs as seen in number 2.
Yeah. Yeah, you can see that the P wave, which is the depolarization, that's normal, right? You just don't have that lag to a QRS complex anymore. And that's it, I think.
Yeah.
Yeah, that's it. So any questions there? Any other questions? All right, cool. So